We'll start our panel off with a national view on research and emerging workforce issues from Polly Pittman, who's the co-director of the George Washington University Health Workforce Institute, as well as the federally funded GW Health Workforce Research Center. Dr. Pittman, can you hear us?
I can. Can you hear me?
You can hear us. You just want to X out that little window there.
I just did that.
All right,
And
and I think we're rolling. So take it away.
excellent. Well, I wish I could see you all. I'm glad you can see me, and I am certainly honored and very pleased to be with you this afternoon to share with you a few remarks about the work that we've been doing, trying to understand the changing configuration and distribution of the healthcare workforce in the U.S. I have to say, having reviewed some of the organizational websites that are present on the panel today, I am incredibly impressed with the work you all are doing in terms of really using policy to make sure that you have the workforce that you need in the right places. It's an area where I think states lead. The federal government has some participation, obviously at the level of funding, particularly residency trainings for physicians, but a lot of the innovative thinking about new models of care and how they relate to outcomes, as well as the thinking about pipelines and incentivizing the workforce to be in the places where we need them is happening at the state level. So hats off to you all for the terrific work that you're doing. And again, it's an honor to share with you a few findings from the work that we've been doing at a national level. So I wanted to briefly run through four topics. I wanted to look at what we're seeing at a national level in terms of changes, primarily in terms of the hospital level and the community health center level as sort of a proxy for primary care. We have done less work in some of the other areas of care, such as long-term and behavioral health, oral health, and community-based health. There are other centers that are working on some of these issues, and I'd be happy to make sure that those relationships are established if there's particular interest in any of those areas. So just descriptively, I wanted to talk to you about what has changed in the last decade or so in those two spheres. Then to share with you some of the findings we have from the studies that have looked at the relationship of new health policies, in particular payment reforms, to these configurations. In other words, to what extent can we explain these changes as a result of different policies? And then really the holy grail is, does this matter? Does this actually affect health outcomes? And eventually, does this affect costs? And that has been an area where, frankly, the field of health workforce research is just getting started. It's methodologically quite complex to establish relationships of causality in this messy healthcare system that we have. But we're working hard in that area, and I have a few preliminary findings I'm excited to share with you. And then lastly, I thought I would close with just some questions that I think emerge from some of our findings that may be an interesting point of conversation with you all. And again, most of what I'm presenting is a result of the work we've done under the HRSA funded Health Workforce Research Center. I've put a little asterisk next to findings or titles of findings that were funded by others. And I have included a few of those to sprinkle in because I think it helps tell the story. So starting off with the community health centers, we have longitudinal data and are able to see from 07 to 13 are the first studies, and actually we've been able to continue to document these trends up to 2015 data using the uniform data set, which many of you know if you've had a relationship with CHCs. They're required to report to the federal government on, among other things, their health workforce as well as some of the quality outcomes. And it's not perfect data, but it's better than what we have in most other data sources. So the big story is that if you were to look at the staff to patient ratios, we're seeing a pretty large growth in the CHC workforce overall in the nation. It's about a 10% workforce growth. When essentially holding steady the number of visits. In particular, we saw mental health and dental health up. Obviously, there's been a strong federal policy and probably state policy as well to try to co-locate behavioral health and oral health in primary care, and we're seeing that in the data. Interestingly, we did not see as fast a pace of growth among substance abuse health workforce, and that's a kind of wonky thing that we're not sure how to explain given the importance of substance abuse these days. It may be that some of that substance abuse staff is actually buried in the behavioral health staff, so it may be a data issue, but it is something to watch. I think that perhaps increasingly social workers are doing some of the substance abuse services. And so at the level of the medical staff, so that's within a category in the data that we call other health staff. Within medical staff, which is basically the primary care providers, the nurses, and medical assistants, we have seen quite an increase, but not all of the different professions have increased to the same degree, and that's where we begin to get some clues about how the model of care may be changing. We don't know why it's changing yet, we just know that it's changing. So the big story there is that the percent of physicians within the medical staff has been not growing as fast as the other areas. So in other words, their section of the pie is shrinking over time. So that is essentially about a 34% growth for physicians over this period. But if you compare that to NPs and PAs, to nurse practitioners and physician assistants, we see a 74% growth, a 43% growth for nurses, and a 60% growth for MAs. So you can see that the primary care MDs and DOs are a smaller proportion of the pie. In terms of the different sectors, it's interesting that administrative has only grown about 3.6, which I think is good news. So we're really seeing more clinicians. The medical is 12%, other health, which is allied, is 30%, and enabling is 6.9. So enabling would be things like community health workers. So we're seeing a real growth of co-location of services and increasing employment of allied health professions in community health centers. So all of that seems to be pretty good news. I wanted to throw a few things out that is perhaps not as good. We see, for example, in the National Center for Health, the National Association for Community Health Centers did a survey last year on vacancies, and the results were quite alarming. There's a 60% vacancy for 60% of CHCs have a vacancy for physicians, 50% for NPs, and 18% for PAs. So clearly, the decline in the proportion of physicians on staff is not entirely by choice, if at all by choice. There seems to be a difficulty recruiting, so that's probably no news to you all, but it's interesting for us to see it in the data. But similarly, there seems to be a real demand for NPs that is not being met, and somewhat less so for PAs. Another study that we did not do, that was conducted by Friedberg and colleagues, showed in the community health center world that there is a decline in satisfaction among clinicians. And that is obviously concerning because we know that is very related to retention. So both of those things are somewhat concerning. We've also seen, in terms of overall, not just CHCs, that Americans report that they, at a higher level, have no usual source of care. So this is somewhat surprising given the expansion of coverage in our country and the emphasis on moving from sort of a hospital-centric model of care to a primary and community-based model of care. And I think there's a lot of digging that needs to happen here to better understand what's happening, why are people still reporting that they have no usual source of care, and why is it actually getting worse. And similarly, we see a real problem in terms of referrals to specialists. So for example, at the level of the CHCs, only 30% of kids that are seen at CHCs are not having a complete referral to a specialist, which suggests that they are experiencing shortages of specialists and difficulties in access there. So even though we have staffed up, so to speak, in the world of primary care, the challenges are pretty serious still, and I imagine in Wisconsin that that's particularly so. Shifting now to hospitals, the data is a different set, but it's the American Hospital Association from 2010 to 14. We've also used some Premier data, which is in associations of hospitals, to try to dig deeper into different kinds of jobs that are not disaggregated in the HA data. So among hospitals, we're seeing a rise in the number of hospitals that are using NPs and PAs. This is a real trend. similar to the CHC. So we're at about 63% of hospitals are using NPs and PAs in all kinds of different ways that we'll talk about in a minute. Interestingly, there is a pretty steady RN to patient ratio when you control for patient acuity. So that seems to be good news. There's a lot of concern about nurse staffing, obviously, because it's been shown to be related to patient outcomes and mortality. There is a slight decline in the assistive personnel that supports these nurses, however, over the course of these years. It's not a huge decline, but it's small. And when we dig into which jobs are actually declining, it's really interesting because here we see what I've tried to describe as de-skilling. We're seeing a drop in the number of high and middle skilled workers as compared to the lower skilled workers. So whereas the first two groups are declining quite rapidly, the lowest group of workers, least level of education and lowest level of wages, is actually increasing. So one can think about the implications of that from the point of view of the nurse workload and potential for burnout. We don't know for sure, but it is somewhat of a red flag. So turning now to what we know about which policies are driving these changes. It may be that other things are driving these changes that are not policies. So we try to control for everything that is not related to the policy, like local density and supply of different health professions, even the economic situation of particular provider organizations, to better understand how we can isolate the effect of particular policies and particular payment policies. So in the case of PCMH, there is, when we control for everything, the effect of PCMH, in this case we're using the CHC as our universe of providers, is primarily to drive the hiring of NPs and PAs. So we see a marked decline in the relative role of physicians, particularly in PCMHs. And again, we don't know why, we just know that there's a statistically significant association when we control for everything else. Based on some qualitative work that we've done, my suspicion is that it has to do with the notion of teamwork. PCMH is very emphasizes teamwork, and it may be that providers or provider organizations are seeing that they really need to build up their advanced practice staff, and that there may be some efficiencies there. So we don't know why this is happening. We just know that there is a relationship between adoption of PCMH and an increase in the number of advanced practice staff. The electronic health record adoption is a really interesting area, and here we've looked at productivity in particular. So we see at the level of staffing in CHCs and primary care that adoption of electronic health records is associated with a more hiring of nurses and of medical assistants. So that's interesting in and of itself. And then the other thing that we see is that productivity tends to drop for about the first 3 years, and then it begins to increase. The productivity overall of the CHC as measured in terms of number of patient visits, controlling for acuity. The data on accountable care organizations is interesting as well. We've done both qualitative and quantitative studies. Although the ACO leaders are talking about how they're changing the model of care a lot, how they've hired community health workers and care coordinators and all of this, in the AHA data, when we look at hospitals, not the entire ACO organization, we actually don't see that occurring. So that's an interesting note. We do, from the qualitative interviews, however, know, particularly with the next gen pioneers, hearing loud and clear that the changes that they want to implement at the workforce level are really happening slowly, because it is very difficult to justify to their chief financial officers that they are going to have an ROI on changing the staffing models, because payment comes so in such a delayed manner. So if you have to wait for 6 months to a year to know whether or not you've had savings and whether or not you're going to have additional revenues, it's difficult to justify those workforce changes. So they seem to know where they want to go with this, but they're having difficulties actually sort of rolling it out because of the internal conversation about the justifications. We've done a series of studies on nurse staffing laws, and that has not actually been published yet, but we are really clearly seeing that the effect of these laws, whether they're mandates or they're required staffing committees or public reporting of staffing levels, do have an effect on the nurse to patient staffing ratios. We are also seeing, however, that they have an effect on the nurse support personnel, suggesting that to some extent there's hospital level decision around staffing up nurses, meaning that they would have less support staff. In other words, they're moving the money around, and again, this is consistent with what we saw in terms of the national statistics in terms of the nurse support staff declining. We've looked at Medicaid expansion to see to what extent it changed staffing and to what extent it changed productivity. The results are underwhelming. Certainly, utilization has gone up in CHCs. We don't see major shifts in terms of how CHCs are staffed in states that have expanded Medicaid versus not, and we don't see a change in productivity. A slight expansion in terms of the number of staff, but very small and really just barely covering, if at all, the increased utilization. So this has turned out not to be a major change in terms of workforce issues. And then, of course, like everyone else, we've been very interested in understanding how scope of practice laws affect both staffing levels and productivity. This is a complex area, particularly because you have to control for so many other variables. But at the level of the community health centers, when we model in different ways, we see a very small effect. When we model, in particular, by staffing, we cluster the CHCs by the type of staff that they have. In those CHCs that have very high physician ratios relative to other kinds of staff, we see an impact in terms of NP productivity in those places increasing where there is more permissive scope of practice. In other kinds of CHCs that are either high advanced practice staff or high nurse, we don't see an effect. So it's somewhat like Medicaid expansion. It's a very marginal effect. It's kind of underwhelming in terms of seeing either staffing levels or productivity. So that's the work we've done in the area of how policies are affecting workforce levels and configuration. The work that we're doing on outcomes is really where we want to go with all of this, and I know that this is what practitioners are clamoring to know. So we have a team of health economists that have been working on what we call a production function, which sort of looks at inputs and outputs and looks at workforce as if it was the point of the realm. And this approach is somewhat different than the studies that have been done in the past on nurse staffing, in that it's not a linear equation kind of a model. You actually get a curve, so you can see where you get the most bang for your buck at what point in terms of hours of a certain kind of personnel in relation to quality outcomes. And at what point are the returns diminishing? And so we did this first in hospitals, and we're working now with the CHC data on primary care. And at the level of hospitals, similar to what others have found before, nurse staffing is very sensitive, in particular to different components of the HCAHPS, the patient-reported outcomes. We saw overall that the percent of hospitals that are understaffed for an optimal level of this outcome is quite high. It's about 70%. What I was really interested in terms of the substance of these findings was that in the HCAHPS, you have patient-reported measures that are essentially about housekeeping types of activities, but you also have others that are more clinical in nature. For example, were your medications explained to you? Were you given instructions upon discharge about how to handle XYZ in terms of future consultations? And we found that the nursing assisted personnel, which was very sort of suboptimally staffed, was sensitive to all of these different measures. And the reason that is important is that obviously they would be sensitive to issues like, was the housekeeping adequate? But one might not have expected the nursing assistant personnel to be so sensitive to outcomes that are really more related to the nurse work, like explaining medication side effects. So we think that this is an important finding for hospital leaders to understand that there is a spillover effect of nursing assisted personnel on their performance on HCAHPS, which of course matters in terms of the bottom line. In the primary care setting in CHCs, we're just beginning to identify which outcomes are sensitive to workforce, and not surprisingly, it's primarily the process measures that, rather than the end result of an outcome, that are more sensitive. And just as kind of a flavor of what's coming, because this study won't be over until September of this year, we are finding that in centers that have well, the first finding that was really interesting is that neither staffing up on physicians or staffing up on NPs and PAs makes a great deal of difference in terms of these outcomes. What does seem to make a great deal of difference is having the nurses, support staff, uh, um, increased in relation, in particular, to NPs, less so for PAs and for physicians. And again, we think that this is about something happening in teams that is really important, and having clinicians have adequate support is a really key, I think, finding of this work early on. So obviously we're interested in this from a methodological perspective because we think that we can move around different settings and different kinds of health personnel to begin to understand their effect on outcomes. But we're hoping that this really expands the conversation about how many warm bodies we need where, but also about in what configuration, what kind of support staff. So I wanted to just close with a few questions on this that we will be thinking about and that you all may also be thinking about. And it'd be interesting to hear from some of you about where you think we should go with this research agenda. The first is that obviously, while we're looking at quality outcomes, we do need to include costs because the costs are about health services management, and so that will be beginning next year. We'll be starting to look at labor costs in relation to outcomes so that we can actually have some findings that are I think more practical in terms of decision making. We are concerned about this finding that there's a decline in the nurse assistive personnel, particularly given what we found with the outcomes. And I think that the conversation around nurse staffing is largely going to be around nurse burnout. In other words, we've moved from just the RN to patient ratio question to how do we have adequate support for nurses so that they don't burn out. We've done a study that is looking at the NP and PA privileging that I hadn't mentioned before, but we're really interested in this. And essentially what we found is that in hospitals, there's gigantic variation in the way NPs and PAs are used across the clinical areas. And so, and that this is not associated with scope of practice laws. It's really a hospital level decision. So our next phase of work is really understanding not only the organizational predictors of that privileging variation, but also what the outcomes are in terms of health. I particularly am interested and concerned about the possibility that despite the incredible increase in nurse practitioner graduation rates, they seem to be being gobbled up by all kinds of different sectors that are not in primary care or even in hospitals. Everything from insurance companies to retail clinics, et cetera. And there seems to be an insatiable demand for this new kind of healthcare worker. And I think that we need to watch that closely. And then finally, I would end with just sort of a big idea, which is, as we think about our payment policies and how they affect the restructuring of the delivery system, I do think that the takeaway from our ACO leaders, which is that this lag time you have to show savings, is essentially a barrier to workforce transformation. So the idea would be, is it possible to start baking in kind of incentives or even requirements around some of these workforce changes that we are learning are effective early into these payment policies, as opposed to leaving it very open the way we do with PCMH and ACO right now. And I think that there are some states and some municipalities that are experimenting with this, and that's going to be an interesting area to watch. So with that, I'd be happy to answer any questions, but I know you have a lot of speakers. Turn it back to you.
Well, Dr. Pittman, we can have you hold on the line, and we'll bring it back for the Q&A in about a half hour. We'll see if there are any questions for the audience then, but thanks for your talk.